Greetings, everyone. It's great to see everyone this morning on World Mental Health Day. And with that in mind, we do have our very own alumni, Dr. Kristen Dial. Not only has she made an impact in the lives of many, but she has changed the shape of how we view care of mental health. Further, Dr. Dial is an alumna of Pepperdine, earning her master's in clinical psychology with an emphasis in marriage and family degree. She has a Psy.D in clinical child psychology from the University of Hartford, and her clinical interests include assessment, chronic medical illness, interdisciplinary care of mental health within primary care, and neurodevelopmental conditions. Dr. Dial graduated from the Leadership Education in Neurodevelopment and Related Disabilities Training Program and the Marital and Child Health Nutrition Leadership Education and Training Program. She completed a postdoctoral fellowship at San Diego Neuropsychology, where she conducted comprehensive neuropsychological assessments for both children and adults. Her clinical work primarily involved providing mental health care in primary care medical settings. Dr. Dial joined the faculty at Pepperdine in 2010 and is the program director for the Master of Arts of Psychology and Master of Arts in Clinical Psychology, online programs supporting approximately 1,700 graduate programs. She teaches group therapy, interventions for children and adolescents, and counseling techniques. We're so pleased to have her join us today. Please welcome Dr. Kristen Dial.
Good morning. It's so lovely to be here with you all. Thank you to Vanessa and her team. Thank you again to Kathy for providing this space. I've had the opportunity to be where you guys are and really have found this space to be so enriching to my own personal self-care as well as my professional growth and development and the ability to make connections here that I haven't been able to make in other places. This is a really unique space, so I'm really grateful to be here. So I'm going to ask you for a few questions to get us started today. So I have a mic and so does Vanessa in the back. So when you think of the word, and this is actually a conversation starter that I do with a lot of my students, one of the classes that I teach for our incoming master's students, this is one of the questions that I love to pose to them. So when you think of the word mental health, what comes to mind? It can just be a phrase. It can be based on your own experience, maybe perhaps what you've seen in social media. Any words or phrases that come to mind for anybody? Mental health.
Safety.
Oh, I love that one. That's a great one. Safety. Other thoughts? All right, well, I'll jump in and let you know what my students tend to say. So a lot of times mental health and mental illness are very easily used somewhat interchangeably. So when we talk about mental health, we're talking about an overall state of mental and psychological well-being. So it is safety, it is trust, it's the ability to be seen and heard in relationships. It's the ability to have our needs met to function in our daily lives, basic things. If you've ever heard of Maslow and his hierarchy of needs, that is part of that as well. Okay, so let's move on. Hopefully there's a little more, there's a few more ideas about what mental illness is and what it looks like. Any thoughts of words that come to mind when you hear mental illness? Kathy, please.
Anxiety.
Anxiety, yeah, good. Other words. My own daughter, hold on. It better be good.
Quiet struggles.
Quiet struggles, that's a good one. Lots of people tend to struggle pretty much alone. Please.
I think imbalance.
Imbalance. So we see imbalance both in life and well as, we know that I was talking to Kathy about this ahead of time. Mental illness is a brain disease. We see imbalance in chemicals, imbalance in the way that the brain is wired and working at any given point in time. Lena, please.
Misjudgment.
Misjudgment. That's a good one too. All right. One more. My mom, because she did raise her hand.
Chaos.
Chaos, that's a really good one. So these are all common words that I've heard before. I've also heard shame. I've heard dangerous. I've heard scary. So as we move through today, we're gonna get through a broad brush stroke of information as we move forward. So we're going to talk some about why some of those words. Think also about the way that mental illness tends to be characterized in our communities on TV. Who are depicted as having mental illnesses? What are they? What holes are they put into? What boxes are they in? Because that often starts to impact the way that we think and how we approach people with mental illnesses. Okay. Just a brief show of hands. How many people here know someone who has struggled with their mental illness? Just raise your hand. And I should hope everyone's hands going up. Okay, so can you leave your hands up? If you have a family member or you yourself, no need to name names, have struggled with mental illness, keep your hand up. Okay, thank you. You can put your hands down. So if you didn't look around, almost every single person still had their hands raised. So you guys are not alone. It's a pretty accurate representation of the statistics in the United States. The National Institutes of Mental Health currently projects that 23%, or roughly 60 million Americans, are diagnosed with a mental illness. So that number comes out to about 1 in 5. Notice I said adults. The slide says adults. Certainly mental illness impacts children. Right now, our statistics show at about 20% of children in the United States are diagnosed with some sort of emotional, developmental, behavioral illness at this point. So how many people here would say that their mental health is just as important as their physical health? Just a quick show of hands. Yes. Okay, good. So a recent Gallup poll basically echoes what you all said. 82% of Americans say that their physical health is just as important as their mental health. So to understand where we are today in terms of America's mental health care, we need to do a little bit of looking into our past because the roots of where we came from are influencing where we are now, at least in my humble opinion. So I've kind of chunked today's talk into 3 sections. We're going to talk about where we've been, a little brief overview of mental health care in our country. Absolutely, you're going to start to see threads of how our past are connected with where we are now. Then we're going to transition into where we are today, the good and the bad. There are both present today. And then hopefully move into some actionable steps, things that we can do as women, as mothers, as caregivers, as leaders, as people who have influence in their communities. So let's get started. And I promise I won't keep the history too long, but it is really important to understand. So again, the number 3 keeps standing out to me. So 3 chunks in terms of our history that I'm going to share with you guys today. So initially, the first steps in the treatment or how we viewed mental illness in our country, we're going to start with prior to the 18th century. Mental illness was really seen as the result of bad spirits, demonic possession, or witchcraft. Our treatments at that point were exorcism and imprisonment. That is how we dealt with it. We often felt or we treated folks with mental illness as though they had some sort of inherent moral failing and that God was punishing them. So that is where our roots start. And there is stigma that started back then that is still with us now. So we'll talk about that as we move forward. So in the 18th century, we started moving away from imprisoning people with mental illness, and we started to move towards care in asylums. Asylums were touted specifically for the housing of people with mental illness. We were still not yet dispensing treatment. Asylums were designed to separate people with mental illness away from their communities and families. We worried that they were contagious. We worried that they could impact other people. And there was shame already starting to grow in families. So some people were fortunate enough to have their family members still care for them and take care of them, but they often had to be shut away from their communities, out of sight, out of mind kind of thing. I should also mention that the treatment of individuals in these asylums was pretty deplorable. People were often living in bedrooms by themselves. They had no contact with the outside world. People were chained when their behavior became problematic to the people that worked at asylums. Oftentimes there was not heating or any way to heat the areas that they were living in. So reform began around the 19th century, specifically around 1840, and it was largely spearheaded by a single woman. My mom's going to love this because she was a nurse. The woman's name is Dorothea Dix, and she was a nurse. And she was really the first reformer for mental health care in our country. Being a nurse, she spent time in asylums and in different medical institutions at the time and saw the deplorable treatment of people with mental illness. It was based on her motivation to improve conditions. She started lobbying a variety of state legislators as well as U.S. Congress to make changes in the care of people with mental illness. By the 1870s, so within a pretty short period of time, within 30 years, almost all states had at least one newly founded psychiatric hospital. Her envision in creating a different level of care was this idea that by providing humane treatment, the opportunity for compassionate care, that those with mental and recreation, so people were suddenly now not locked in rooms, they were given the opportunity to garden, to cook, to read books, to be in community with each other. And the idea was that this would decrease mental health symptoms or even be a cure. Unfortunately, that didn't turn out to be the case, but she was moving in the right direction for sure. Early in the 20th century, around the 1900s, if you've ever heard of Sigmund Freud's ideas and some of his colleagues' ideas about how we can treat mental illness started to be used in the United States. Freud postulated this idea called the talking cure. It is one of the foundational components of psychoanalytic work. And we still today in mental health use a number of tenets that Freud postulated back in the 1900s. There's a downside though. Freud also postulated a number of ideas about mental illness that really have stuck with us and that have created a really tragic situation in terms of how our communities approach mental health care. And I'll give you just one little example. So Freud believed that it was mom's fault, all of us, for creating schizophrenia in their children. He had a really fancy name for them called schizophrenogenic mothers. Despite years and years of research to dispel many of the ideas, some are good, but some are bad, to dispel many of the ideas and tenets that Freud postulated, I've worked with parents who've said, I'm not going to get care for my kid because it's my fault. Something bad's going to happen to me. So we have still hung on to that tenet. That is part of our stigma in mental health today. All right, so moving beyond Freud. Now we're moving to about 1930s. Two new treatments came on the scene for mental illness. One was electroconvulsive therapy, ECT. That is when we send electrical current through somebody's brain in order to reboot it with the idea that we can return it to a place of homeostasis. So ECT was originally designed to treat schizophrenia. It is actually still used today, although much more safer with things like anesthesia and muscle relaxants. ECT, I said it was originally designed to treat schizophrenia. We're actually finding that it is very beneficial in treating chronic and difficult to treat forms of depression. So we've made it safer. There's no long-term side effects for people, particularly with the use of medications. The second form of treatment that we started to use in the country around the 1930s in our country was lobotomies. So this was neurosurgery with the idea that if we severed the connection between the prefrontal cortex and the frontal lobes, that we would decrease mental health symptomology. We decreased a lot, unfortunately. Over 40,000 people in the United States received lobotomies before we realized that there are catastrophic effects from doing that. People who were capable of walking, feeding themselves, dressing themselves, and reading and writing often were left no longer able to do that. And there's roots in this one, in this story about lobotomies, because we're going to hear how President Kennedy, his impact of his sister actually being institutionalized and receiving a lobotomy, spearheaded his movements, his legislative acts a little while later. So we'll get there. So lobotomies are no longer used today, but they were pretty consistently used in the United States for quite a while. So beginning in the 1950s, we had new psychoactive drugs that came on the scene. So pharmaceuticals were synthesized to target the treatments of schizophrenia. So the two that came on the scene and that still are used today are lithium and chlorpromazine. They were effective in treating about 70% of people with schizophrenia. So we had a huge breakthrough at that point. We had a drug that could very effectively, 70% is a pretty good effective rate for a drug. And so with that, started the move to our last phase is the deinstitutionalization movement in mental health. So this was the idea that well, let me get through the pieces that contributed to the deinstitutionalization movement. So we had new drugs. We also in this country at that time had the civil rights movement going on. And they highlighted that group of individuals looking at civil rights across all people, really were looking at the moral implications of forced treatment. People who were living in asylums and psychiatric hospitals were not there by choice. We put them there as communities. We designated a space away from us for them to live at. They also were concerned with long-term hospitalization. So we were not so good at treatment yet that people were leaving hospitals. Once they checked in, they often didn't check out. They spent their entire lives there. The other concern that folks in the civil rights movement had was this idea of restrictive care. And so today in mental health and in a lot of different medical disciplines, we have this concept of least restrictive environment. And that is still a moral compass for us in mental health today. In what setting can we provide effective treatment that is in the least restrictive way? So we have everything from inpatient treatment that usually doesn't last more than a few weeks or a couple months for people. We have outpatient day treatment programs, which can be every single day, or it can be half days. And then we have outpatient treatment where you are showing up and seeing somebody typically for an hour and a half, once or a couple times throughout the week. So that piece is stuck with us. So we have the use of psychiatric drugs, the civil rights movement, and here comes my piece back around President Kennedy. So in 1963, President Kennedy, along with really good support from his sisters, who all had seen their sister Rosemary, who was, his mom Rosemary, or his sister Rosemary? Anybody remember history? Sister was Rosemary. Okay, so his sister Eunice and him had seen, once they were allowed to know what happened to their sister, who was in an inpatient asylum and then had this neurosurgery of a lobotomy performed on her. So in 1963, President Kennedy signed into law the Community Mental Health Act. The goal of that was to provide federal funding for community mental health centers, as well as funds for research in the United States towards the treatment of mental illness. So that's the good news. Unfortunately, 4 weeks later, President Kennedy was assassinated. And so his act never really got implemented the way that he anticipated. There was also a follow-up piece that he needed to include with long-term funding that didn't happen. He limited his act to get it through, to get enough yes votes, and then he was going to come back with a second ask for more money later. But in its original state, he had envisioned 1,500 community mental health centers being funded throughout the country. In actuality, less than half of those were built. Very few were actually fully funded, meaning funded for building, staff, and then ongoing care. So that act also cut 90% of inpatient psychiatric beds, none of which were replaced in community care. So the reason why we had this great shift from this really lovely Community Care Act was funding. So President Kennedy felt as though this was a federal issue, that federal dollars should be used to care for people with mental illness and to fund research. There was some popular legislators who didn't believe that that was the case, who felt that it should be at a state level, and we had really drastic cuts in funding. For us here in the United States, or up here in California, Governor Reagan and then President Reagan actually made really substantial cuts to the funding of federal mental health care. I don't want to talk politics, but that is the storyline. So sheer numbers, by 1980, 430,000 people who were previously living in psychiatric hospitals were released. Psychiatric hospital doors were closed, and they were sent to find community care. We did not have a workforce to help them get from those doors closing back into their communities. So as you can imagine, this left a lot of people showing up at ERs, emergency rooms, for emergency psychiatric care. This left a lot of people who had likely already, because of their mental illnesses, had created really challenging relationships within their families to where family members were not willing to house them. And we started to see our homeless population's incidence of mental illness rise. So deinstitutionalization, as you can imagine, if you talk to most mental health folks or community activists, public health officials would say that it had really mixed results. When community mental health care services are comprehensive and accessible, people do well. We see better long-term outcomes. But for many, community alternatives didn't exist. So unfortunately, from the deinstitutionalization movement forward, we have seen an enduring pattern in our country of using jails and prisons as primary care providers, even though they're not equipped for that role. Jails are designed, in my mind, to punish people. That's what they do. And unfortunately, they do it well. That's not treatment for people with mental illness. So the other sad point, and I'll promise I'll get to some things that are a little more uplifting. In my mind, we've come full circle. We have come back to the original days of imprisoning and criminalizing people with mental illness. And that is tragic. That is the tragic piece of the story. And hopefully through there, we're going to get to the stigma and how we can work with some of that. Unfortunately, for those of us living in the United States, nowhere is our mental health crisis more clearly evident than in our LA jail system. Currently, today, the Los Angeles jail system is considered the largest mental health institution in the United States. It is only second to Cook County Jail in Chicago and to the Rikers Island Jail Complex in New York. So those are the 1, 2, and 3 numbers. So where are we at now? How many people here would say that in our country, we are in a mental health care crisis? It was kind of on the topic of my talk, but thanks for raising your hands. Anyways, I appreciate it. I realized that after I put the slides together and sent them in, I'm like, oh, I think I don't need to ask that. Okay, so for those of you who raised your hand and nodded, yes, you were in good company. In 2022, CNN and the Kaiser Family Foundation did a national survey where 90% of the respondents agreed with you and said that we have a crisis of care in the mental health community. Additionally, respondents also ranked mental health as the top healthcare concern in our country, above obesity, cancer, and stress. All right, so this is my good and my bad news. I'm going to start with the good news just because we went through that. The history is always a little, takes my breath away still, even though I'm familiar with it. So to better understand where we need to be, I want to spend a little time going over what we're doing well currently in mental health care and where our gaps are. So we're going to start with the good news. Okay, so we really have come a long way. Science has revolutionized the treatment of mental health. We just need to kind of catch up with the care piece. So I'm going to kind of run through this bullet point list. This is not an exclusive list. These are the ones that I feel are most impactful to the mental health community. So I'm just going to run through them quickly and share them with you. So neuroimaging. While mental illness is not associated with brain lesions, much as we might see after someone has a stroke, neuroimaging, particularly functional MRIs, have been able to map the circuitry involved in a variety of mental health symptoms. So we can see pathways light up in the brain, for example, when somebody's experiencing a flashback that they might be experiencing after having a traumatic experience. Because we can see that, we know that it's a circuitry issue. We are not talking about gross structural abnormalities. It's how the brain is speaking to each other or not speaking to different parts that is responsible for a lot of the symptoms we see in mental illness. Knowing that gives us an avenue of treatment. We can stop some of those pathways. We can support some of those pathways. So neuroimaging. Genetics mapping. So gene mapping has identified genes associated with a variety of mental illnesses, particularly schizophrenia and forms of depression. Because of that, we are able to create personalized approaches based on the genes that are implicated. We can also create an assessment based on genes, so a genetic risk assessment, which will allow us, we'll get to it, of early intervention is what that allows us to do. But it's also allowed researchers to consider the use of gene editing technology, such as CRISPR. CRISPR is really amazing. If you're not familiar, look it up. It's a really long lecture, and it's not my area of expertise, but that is one of the advances, and that is what scientists are currently working on. Okay, early identification and intervention. So this again is at the forefront of mental health at this point. I'm sure you guys have probably seen some public service campaigns that point to this, but early identification allows us to assess people early for the onset of mental illness, which allows us to intervene early when symptoms are small and not as pervasive and not as chronic and not as debilitating. That is important. We also know that when people wait to seek care for mental illness, when there is a crisis, their ability to return to a place of homeostasis decreases. It has a longer-term effect. So getting things identified early. So I can give you one really great example. I did this work at CHLA. So the identification of children that will be diagnosed with autism spectrum disorder. We can identify that now, believe it or not, pretty close to age 1.5 to 2 years old. We do it with children sitting in high chairs. We are pretty good at identifying that. We would put them in a high-risk category. We wouldn't make diagnostic impressions at that point, but it allows us to start to track that kiddo. It allows us to lend support to that system, which we'll get to too. That's one of the good upcoming things. So early intervention services in the long term minimize the long-term implications and limitations of people when mental illnesses are allowed to get big and chronic and in crisis mode. What's next? Evidence-based intervention and recovery. So evidence-based interventions, I teach this in every single class at Pepperdine. It's great to have a theoretical orientation. It's great to love Freud's work. But if it's not evidence-based, if there is not rigorous research that proves that that treatment intervention is good at alleviating the symptoms of that condition, we shouldn't be using it. And that is the push of where our field is going. I constantly talk to students who say, oh, I really love this theory. Well, that's great. But for whom does that theory work for? For which population? And then you have to get a little bit more fine-tuned to really look at the research evidence to say, okay, this works in kids ages 8 to 12. This is what we consider to be evidence-based. But then we have to look at our research. Who is our research based upon? Who is included in those models and who is excluded? So always put that piece in there, evidence-based for whom. So we're making really good milestones in evidence-based intervention. The most common one is probably cognitive behavioral therapy. Many of you, I see some heads nodding, have heard of that intervention, but frankly, so is parent training. Parent training is considered an evidence-based intervention because helping families and systems support people who are struggling is critical. We need them not to burn out. We need them to be able to manage that at home. I was sharing with Kathy that I always get a giggle when my students who want to go into child psychology say, I really love kids, but I don't love adults. And it kind of makes me scratch my head. And I said, well, how are the kids coming to your office? How are they going to see you? Oh, well, their parents will bring them. Okay. Who's consenting for treatment? The parent. Who do you need to ethically to inform about the treatment you're doing? The parents. So I'm like, I love kids too, but we do need to learn to be able to communicate with the adults that bring them and support them. My 1 hour in a clinic with a kiddo does almost nothing. But what it does is allow parents to watch me. It allows parents to learn the tools that I'm using. It's not rocket science. I've just spent a lot of time in school. They can learn it. We should be teaching parents how to intervene with their children themselves, empower people. It's not about me, it's about that family. I want them to succeed. I want the entire unit to be able to master this and move forward. And I'm just there as a buffer. Call me. If you get stuck, let's strategize. Let's figure out how to do this. So evidence-based interventions are super important. The last piece there is one of my favorite, the recovery model. So this is now integrated into almost across the country, all educational curriculums for folks studying mental health. It is also required by, in California, the licensing board, the Board of Behavioral Sciences, that we teach through a lens of recovery. So what does recovery mean? Recovery is the emphasis that we need to move beyond just symptom reduction. And I love this notion that we need to treat the whole person. We are not just symptoms. We are not just a score on a test. We are not just the amount of sleep we get in night. We're not the number of flashbacks that we have through the course of a day. We are whole people, and we need to be doing whole care. So the recovery model embraces all aspects of people's lives. We look at housing. We look at access to healthcare. We look at nutrition. But mostly what I love is that we focus on purpose and meaning. Purpose and meaning are important in our lives. I'll get, that's going to come back in this lecture. Okay, so digital mental health tools. This is kind of relate to your guys' handout, particularly the bottom part. So digital care options have exploded since the COVID-19 pandemic. The developments and the validity of online platforms with which to do psychotherapy through. Think of a HIPAA-compliant Zoom platform where you can log in, gain access to a treatment provider that fits your needs and your schedule. But we also have a whole host of apps that were developed to extend treatment. So think about, you spend an hour with a therapist, they're teaching you some cognitive behavioral skills. They're a little abstract. It's a little hard in your daily life to figure out how to use them, how to fit them in. There are apps that are research-based, evidence-based. Those are the only ones I put on your take-home sheet that really can extend and improve the impact of mental health treatment. So instead of maybe coming in and seeing somebody 3 times a week, you can cut down to once a week because you have an app. And a lot of times those apps will communicate with your providers. So we'll get there. But in general, we're seeing that the use of technology is decreasing challenges with access. It's decreasing stigma because you can now click a button and join online, as well as improving our ability to dispense education about mental health and what we know works for people. All right, within digital mental health tools, there's three specific things that I want to mention to you. One is being used currently, two are still under development and being researched. So one is wearables. So much like your smartwatch or your Fitbit that you might wear, we are using wearables as a way to gather data about people in the mental health community. And that data automatically syncs with your provider. Your provider can look and see trends in sleeping, eating, heart rate, activity levels. And for some mental illnesses, we see changes in those very basic biometric data to where we as providers can say, hey, I'm looking at your numbers and I think we should schedule another appointment. I know you were just here 4 days ago, but come back in. So that allows us to provide care quickly before symptoms get to a point where somebody perhaps is not functioning in the same way. We don't want people losing their jobs. We want people to stay engaged with treatment as well. So wearables is a really interesting tool that is being used now. Two other ones, AI algorithm models. I know AI sounds like, I know we've been talking about AI a ton at GSEP, try to get ahead of the curve. So AI algorithm models are designed to detect and analyze very simple parts of behavior, parts that a therapist could keep tabs on, but an AI doing this is much more accurate, it's faster, and it can be collected at multiple points throughout the week. So these models basically analyze speech patterns, facial expressions, and other behavioral cues. So we have actually pretty rigorous research that shows for somebody who suffers from bipolar disorder, this is just an example, and who is perhaps getting ready to experience another manic episode, we see changes in their speech patterns. We see changes in how fast they're talking. We see changes in the kinds of words they're using. That's a cue to us. That's preventative care. If we can get in there and say, oh, come in. I think we need to meet face to face. I'm seeing some things that are concerning me. Can I connect you with your prescription provider because another medication might be helpful to you right now? So that is still under research, but there's good research right now that it's pretty effective. The last category that I want to share with you is AI chatbots. So we are literally producing therapists as AIs, and mental health people are part of this discussion, part of this development to humanize what an AI might look like, to give them friendly faces, to teach them to lean in and do some of the things that we know can make people comfortable. So while I don't think, and this is me personally, and maybe I just don't want to be out of a job, but I don't know that AI therapists are perfect for everybody. But there is research that is demonstrating pretty consistently that for people who would otherwise not go to therapy because of the fear of stigma and being judged, they would see an AI therapist. And I'm just going to say an AI therapist is better than none. The other thing about AI therapists, we can create AI therapists that can seamlessly move between 5, 10, 100 different languages. That is really hard to find in a therapist. We know therapy is best done for people who English is not their first language. It's best done in their native language because there's words that just don't translate, which decreases the pool of available clinicians if you only want therapy in Farsi. We have a shortage. We have a shortage of mental health providers in general, let alone ones that have specific language skills. Think about an individual who's deaf. How many clinicians out there? I know my daughter loves us. She's is really good at ASL at this point. But how many clinicians do you think out there fluently can speak in ASL and don't need a translator there with them? There's not many, to be honest. There's really not a number that I could find. I tried to look it up. Also think about cultural values. We can integrate culturally specific and relevant information to patients into an AI that would be much harder for a clinician to pick up on. So while not ideal, I see some faces out there that like the chatbot's not what people would necessarily want. There are some advantages. Okay, and the last one, preventative care. So in the fields of mental health, and this is an area that I've been engaged in throughout my career, most of my hospital work was in places that embraced this idea of preventative care being combined with mental health care. So we are still behind in our country. Our medical community has done a better job of putting an emphasis on prevention and physical health care, but we are moving in that direction. We have a number of school-based interventions, for example, that really work with youth, not just around emotional intelligence, but we also have specific programs to combat bullying, racism, and the onset of what we know now to be depression and anxiety in young people, because it can start that young. The building blocks can be set in those young ages. We have community education programs where we are trying to decrease the stigma of mental health and increase the likelihood that people will come visit us. We are good at screening high-risk populations. So I recently took my daughter to her last pediatrician visit because she's going to age out. She had to fill out a screening for depression and anxiety. If any of you have given birth, a lot of us will have filled out some paperwork to ensure that we aren't developing something such as postpartum depression. So we are good at targeting some at-risk populations. We're moving at least in that direction. We're also getting better about incorporating mental health good practices. So meditation used to be something 10, 15, 20 years ago when I was in school. We never talked about that. That was not something that was part of care. We hear about that now. We hear about the importance of nutrition. We hear about the importance of exercise. We hear about the need for self-care, meditation, those kinds of practices. The last two pieces are the increase of employee assistance programs that work to provide people with mental health care and also decrease the conflict with their work schedules. So providing them just a little bit of grace to be able to take care of their mental health. And the last place that I would say that we are starting to integrate preventative care for mental health is in hospital settings. And it's really children's hospitals at this point that I've seen that are really doing a good job. I would say the VAs would be second because there are trained mental health staff there 24 hours a day integrated into departments. When I was at Children's, I worked in the ER. I flexed, I rotated. I worked in neurology, I worked in hem-onc oncology, and I worked in their developmental feeding clinic. The idea was these were all children that we were treating for medical conditions, but we realized that the mental health component goes right along with it. And it goes right along with their family's process and their family's journey. Working in hem-onc oncology with children with cancer, some of whom were terminal, was probably the hardest work that I've ever done, but those families deserved support. They deserved care, to have somebody walk alongside them in that process. Okay, so now we're going to get to what's not working. So while we have effective evidence-based interventions, we have, okay, I didn't change it. While we have lots of psychosocial supports that we're working on in this country, and more than at any other point in our country's history, people are engaged in mental health care. We've studied and we understand the risk factors for suicide. We have new hotlines that have been launched in the last few years. According to the Centers for Disease Control, the suicide rate in the United States has steadily increased over the last 20 years. We've seen a 36% increase in our national suicide rate in the last 20 years. And in 2023, more than 50,000 Americans died by suicide, which is more than any other year in our history. While we have successfully identified neurobiological pathways to mental illness, specifically addiction, the rate of overdose deaths have increased threefold over the past few decades. Roughly 100,000 people die in America every year from an overdose. So just those two numbers alone should give us pause. So where's the gap? And there is a gap. We understand more about mental illness. We have more treatment providers. We have more people engaged in mental health care. And yet the state of our mental health care in 2024 is worse than it was 20 years ago. Just think about that. Think about your oncologist saying, we were better 20 years ago at preventing, detecting, and treating breast cancer. It would be unheard of. It would be unheard of. And yet that's where we are in mental health. So despite our scientific progress, I would agree that our system is broken. Some would even argue that we don't have a mental health care system, but instead we have a sick care system. Most Americans still seek mental health care during a crisis in an ER, and ERs are not usually well staffed to take care of mental health crises. That care is also dominantly focused on symptom alleviation with medication. It is not on treatment. It It is not on recovery. It is not on integration back into someone's community. So to address this gap, a recent Gallup poll started to look at the disconnect between our knowledge and the effective treatments. And these are the results. 52% of Americans cited cost of mental health care as deterring them from engaging. 42% cited access to care, even when they had insurance that provided coverage. When they would call, what do you think the average wait time was? Some people, it was 4 to 6 weeks. When you are in a mental health crisis and you finally decide to pick up that phone and say, I need help, and they say, we'll see you in 6 weeks, you lose people. You lose people. That's not fast enough. Stigma and shame is still listed as 27%, and treatment will not help. So a quarter of the people responded that mental health care wouldn't help them. So when I look at this, I see an engagement issue. I see that we still have people who are dissuaded from mental health care due to cost, due to difficulty finding a provider, and due to ongoing stigma. So in addition to these engagement issues, what I'm going to call this, our U.S. Surgeon General, Dr. Murthy, recently identified 2 more mental health challenges that are impacting our communities and across America. And I'll explain what both those graphics are. So the first one is research that has pretty unequivocally shown us that the impact of social media on youth is having disastrous effects on their mental health. Research shows that after youth spend more than 3 hours a day on their devices, their risk for depression and anxiety double. In 2024, what do you think the average number of hours were? You can't answer. Sorry, she knows the answer. She's heard me practice. What do you think in 2024, the average young adult and adolescent, how much time do you think they're spending in social media? Just hands. 8 hours, right? Of course. So on average, 4.8 hours. So we're almost at 5 hours when our threshold for being at double the risk for mental illness was 3. Research also shows that youth who are engaging in social media sleep worse, have poor self-esteem, and poor body image. So the second image over here, I chose to depict the concept of loneliness. So Dr. Murthy, I love this phrase. He says, loneliness isn't just a bad feeling. He puts loneliness on par as an epidemic as the use of tobacco and obesity in our country. It undermines our physical and our mental health. I'm going to look at my notes because there's a lot of statistics coming up just to kind of drive this point home. The physical health consequences of insufficient connection include a 23% increased risk for heart disease, a 32% increased risk of stroke, a 50% increased risk of developing dementia for older adults, and lacking social connection increases the risk of premature death by more than 60%. So just let that soak in. That's just being alone. It's being alone. It's that simple. But it doesn't have to be this way. So I'm going to share with you 2 quick stories. Vanessa, am I okay with time? Okay. So I was at a work event, an all-day work event, and I had the opportunity to be in community with my colleagues and my peers. Also the opportunity, you can move in the shade if you're uncomfortable. There's spots right up here. So I had the opportunity to do this full day event. It was meant to be an enriching time. It was. Vanessa's team did a great job, as always. But in this panel of speakers, one of my colleagues, after hearing everybody talk, said something really simple. She said, I just want this to be a place of care and connection. And after spending 9 hours, that is the only piece, don't tell anybody else, that's the only piece that I really remembered. That's what we're trying to foster, a place of care and connection. And I did tell her that, by the way. My second story happened here at this event, and it happened a couple months ago, but it's kind of a fun story, so I'm going to share it with you. So I just finished, just like you guys, being enriched and blessed by a speaker who was sharing their knowledge and their talent with us. And I was standing in a line of folks. Well, I didn't know it was a line of folks, but had a cup of coffee standing in line of folks. I wanted to thank the speaker for their time and their effort and energy. I see you laughing. And I turned to go to work. And with my cup of coffee, I dumped it all over another participant who was here. So it seems like a really simple story, albeit embarrassing on my end. But the woman who I ran into responded with grace and with kindness. And that interaction stuck in my head for months, until something funny happened. In my world, it would be God. But I was sitting in another group of people, and there's the woman I spilled coffee on. And I thought, you know what? I'm just going to go own this. I'm just going to go and say something. So I walked up to her and I said, do you remember me? I literally said this. I'm the one that spilled coffee on you. And she said, yeah, I remember. And then she gave me this huge hug. That wouldn't have happened if this space didn't exist, if I chose to not get up and fight traffic to get here, and if the person who I ran into wasn't filled with grace herself. Lena, I still owe you dry cleaning. She's here. She even came to listen to me today. But what a beautiful thing, because now I have a friendship with her. Yay, yes. She wasn't mad at me, right? She's keeping her glasses on because I'm embarrassing her. But it was a friendship that wouldn't have happened without all of those theories of events happening. So how do these stories connect with our topic? So I'm going to argue with you that the gaps in our lives and in our mental health care, that the solution's right in front of us. The solution is each other. And it seems so simple. When I came to this conclusion and I realized this is how I'm going to kind of put my period on the end of this talk, the ability to connect, to be valued by others, and to be in a trusting relationship, we have known in mental health that that works for decades and decades. I talk to my students all the time, although I didn't see it at this level until putting this all together. We see in social psychology, we see that as social support goes up, mental health symptoms tend to go down. And when social support is low, mental health symptoms tend to increase. We know this. We know this. It's not new. So I'm just going to plant a seed in you guys today that relationships are a place of acceptance, well-being, and even healing in our lives. Okay, so this is a quote that if anyone has ever heard of the book, The Body Keeps Score, it's a book about trauma and how trauma is stored in our bodies and how it impacts our brains. This is a quote from that book and from the author. It says, "No doctor can write a prescription for care, love, and friendship." Which of course we cannot, so it's very wise. Okay, so I originally had designed kind of a table talk interaction with each other. And if we have enough time, we can maybe even practice this as people are going out. But I would love for you just to turn to someone next to you and engage them in one question. Ask one question. Any of these questions, get an answer. Let's just take 5 minutes. Do that real quick, just real quick. Turn to somebody next to you. So thank you all for taking the time just to sit and chat with somebody next to you. So I hope that that discussion, just a really small glimpse into how easy it is to start to be in connection with other people, to normalize mental health. If you noticed a lot of these questions, click with mental health and mental wellness. But we often don't know where to start. That is a really common thing that research has shown us, that while we believe mental health is important, we don't often know how to talk about it. We don't know how to ask about it. Oftentimes we feel like asking about it is going to make the problem worse. That is not true. That won't happen. And that's not what research says. So these questions, you'll see the topic here, say it out loud. On your handout, the first 2 pieces that are listed there There is a QR code for one, and the other one says seize the awkward. Those are basically conversation starters. They have different phases of kind of how easy they are, such as where do you find joy? And then they move all the way up to more complicated questions about how does your culture and your family values and backgrounds influence your comfort and your ability around your mental health? How do those two things intersect? So some of them, particularly the Say It Out Loud, was really designed for adolescents and young adults, but they are very easy questions, very easy to turn into something that you can utilize. So I hope you'll take some time to look at those. All right, so let's get to our last slide, and then I'm happy to navigate any questions you all might have. So some of these things are going to sound really familiar to you, but I'm hoping to put a little bit of a spin on them so that there is something novel and new for everyone to take away with them. So self-care practices, the phrase love thyself comes to mind, but it's also when we are taking care of ourselves, we model that for other people. We model it for our family. We model it for our children, our grandchildren. We model it in the places we work at. We model it in the communities that we live in. When I, as an instructor, take pause and say, hold space for some of my students who are struggling because they live in Georgia and who have been displaced and are operating from a hotel room. When I hold space and I say your mental wellness matters to me, are you sure you should be here today? Maybe you need to take some time. It's okay just to lay in bed and watch TV for a little bit. You've been through a lot. That is me modeling self-care. That is me modeling that I value their wellness, and that sometimes pushing through is not the best plan for us. So the two words that I want you to think about when it comes to self-care is routine and boundaries. Just simple way to kind of chunk those pieces. So it's great to engage in self-care, but if we don't make it routine, if it is not a really consistent part of our lives, it's not going to be very effective. It's great to go on a retreat every once in a while or have that treat spa day. I love those things, but they don't sustain me for a long period of time. So think about creating a routine around self-care. This can be simple things. Sleep hygiene. How do you go to sleep at night? When do you go to sleep? What distractions do you have? Put your phone away, turn your TV off. Quiet, 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 quiet. So things like sleep, exercise, nutrition, meditation. The other big one, be intentional with your time. Try to avoid overcommitting. We live in a day and age where we are going to be bombarded with things that will keep us busy. So we do need to protect our health. We do need to protect our peace. Around boundaries, this is really around the kinds of things that we give our time to. I, just like everybody else, I have Facebook on my phone. That's the only one. And the occasion that I turn it on and I flip through it, I stop and I think, I just wasted my time. It really didn't fill me. It didn't provide much value. And I've neglected something else that could have filled me. So by setting our own boundaries around social media, we can influence our families. I would encourage families that have influence over little human beings to have rules about phone usage, because they will use it even if you don't want them to. At least that's what happens in my house. The other thing I would suggest is setting your own boundaries around time and your use of social media. Your phones, believe it or not, smartphones keep track, and they can tell you how much time you have been engaged in news and reading or social media or something else, texting, phone calls. So I would suggest using all of those things. Model appropriate social media behavior. Okay, the next one I think is really the biggest one. I'd love to spend the most time and the rest of our time on this one. So building resilience. Resilience is this concept that came into the scene in mental health when we realized that we can take a group of people and they can all go through a really challenging experience, the exact same experience, because it's just happening once. And a chunk of people seem to come out on the other end unscathed. They are still able to engage in their daily tasks. They're not having disruptions to their sleep. They're not having tummy aches. They're not having headaches, tummy aches. Sorry, you know, I work with kids when I say tummy aches. I always tell my class it's time for a potty break, and I always laugh at me. Sorry about that. So a chunk of people exposed to the exact same thing will become symptomatic, and a chunk of folks won't. So we wanted to know, what does this group have that is allowing them to ride these waves and not drown and not suffer? And that's resilience. So when we look at key factors, we can build resilience. Resilience is not just innate. It is something that we can train our minds and our bodies to do, and we can support others in developing resilience as well. So some of the key factors that leads to resilience. One is challenging our negative thoughts. So I know we all do this. I know it seems simple, but the other day I was so tired that we have a dog at home, and I was cooking dinner, and it was about 7 o'clock. Well, I cooked dinner, we all ate. 7 o'clock at night, I'm sitting on the couch, and our dog's looking at me. He likes to beg. He just stares at me. And I'm like, it's not bedtime. You don't need a snack. Why are you staring at me? I didn't feed him dinner at 5. And I'm like, oh my gosh, how did I do that? I'm so dumb. Those were the words that came out of my mouth. That's a negative thought. That impacts how you think and feel about yourself. A simple phrase like that. When you catch yourself doing that, work hard to create something positive. Our mistakes are opportunities for growth. That is the most common one. A failure can be turned into an opportunity to learn and grow. A mistake like spilling coffee on somebody could be an opportunity to be in a relationship with somebody. So there are ways to change that. Really important, but really hard to do. There are journals and workbooks. There's apps on your handout that will help you challenge negative thought patterns. You can literally type it in, and an AI will recreate for you a positive statement that you can integrate. Something simple as a mantra, a positive statement that you say to yourself over and over and over again. I do this with my students every time they leave class. I put a new one up on the screen and we repeat it together. Something simple. I'm worthy. I'm capable. I deserve to be here. Research shows that it has an impact. Our words matter. Our thoughts matter. Okay, the second piece, everyone here I'm sure has heard of gratitude, but actually making it a routine and practicing it. It impacts your mental wellness. There is also an app on your page called Happily. That will help you practice gratitude. If you don't know what it is, if finding a routine is hard, it will send you a reminder if you send it to. Every night at 8 o'clock, whoops, didn't practice gratitude, I'm gonna go do that. Give me 5 minutes and you're gonna go do that. So there are tools out there that can really help you if you don't, you've heard the word gratitude, but you don't know how to put it into action in your own life. So there are resources that will help you, and all of the apps on the handout that I gave you are research-based and proven to be effective in the things that they do. The last piece is a growth mindset. So it was actually in the medical community where growth mindset was really researched well among residents. And today's language, I think of the word grit, right? That's a word that we're using a lot lately. So growth mindset is grit. It's the ability to improve through effort, learning, and persistence. So we don't have all innate gifts and skills. We have some, and hopefully we're all using those in a way that benefit others. But we can learn. We still have the capacity to learn. So a growth mindset will open up new possibilities for you. Try something new. I read a book about a woman who went through a medical treatment, and all the medical providers were telling her, if it hurts, don't do it, right? Don't engage in that activity. But the person who finally treated her 10 years later said, no, 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 no. You need to do every single thing that hurts. You need to push through that. And that's that idea that by pushing through discomfort and things that are uncomfortable, her book title is something about like, just say yes or something like that. So have boundaries, but don't avoid things when they're uncomfortable. Say yes. When Vanessa said, would you come speak to us? I thought, oh gosh, I'm used to lecturing in a classroom, but this is going to be really different. I'm not so sure. And I literally sat on it for 24 hours. And then I thought, the space has been, this is literally what I said to her, space has been a blessing to me. So if I have the ability to give back, that's what I want to do. So growth mindset. How can you say yes to things that you would ordinarily say no to expand your well-being? The last two the points are really, Kathy has been a stellar example of community and connection for us. I hope that my story of connection here will stand out to everybody when you're tired and don't want to get out of bed next month. But being in community and connection with people matter. And it's not just sitting next to somebody. That's part of it. You can be personally enriched. But to be enriched by somebody else means you have to be connected with them. You have to talk. You have to be willing to spill coffee. Don't spill coffee. You have to be willing to go. Hopefully my face was mortified. I know it was. But you have to be willing to engage and be engageable. You have to be willing to receive on the other side, to meet somebody with grace and connection. All right, guys, are there any questions I can answer? That is my full circle talk for you guys today. So are there any questions that I can answer? Thank you. Thank you. Thank you.
Good morning.
Yeah.
So I loved your concept of care and connection. And my question is, how many people could not receive that in their home? Because in the old days, before we had institutions, we always took care of our children or elderly, whoever needed the mental health. So I guess my question is, of course, we'd want to do it ourselves in our own family, but how many people truly, if you have the number, have to be institutionalized or need professional help, and if the family with care and connection couldn't do it?
Yeah, so that's a really great question. And I don't know that I can kind of project out. If you look, there are other countries whose mental health care stayed connected with community and connection. Spain is one of them. So if you wanted to look for a gold star model, that is one where communities work around and with people with mental illness. They are given purpose and meaning and jobs. And it's not the question that they give in their job interviews is, what are you capable of doing? What can you do? Because that's how we're going to put you to work in the community and integrate you into care. So I don't have a number. I think it's really hard. It's hard to get numbers on the people who are well cared for in homes because they're usually not the ones whose data's we're accessing. But I think as mental health providers and as community members, we can do a lot to support the people around us. I have a neighbor who lives next to me who's a single woman, and her husband died suddenly a couple of years ago. And I think we would say she's a little grumpy. She's a little grumpy of a lady. But I've started this conversation with her and this idea around depression and what it meant to lose her husband. And mental health care was never on her mind. It was never there. But is she having symptoms? Probably. But I check on her. I hear her feed her dogs every morning, so I know that she's awake. She does have children, but her children do not live close to her, so she's pretty isolated. When I have a meal or we make a sweet treat, I take that over to her. We walk dogs, we visit with dogs together quite a bit. So I don't have a great answer, but it's a really great question because I'm sure there are absolutely families and communities that do that better than what we're doing right now in the United States. You have a follow-up?
But it makes us all more conscious now
Yeah.
of looking for family, friends, neighbors, strangers. We could be kind to who might have the need. So thank you for
Yeah.
that.
Absolutely. Thank you. Other questions?
Yes, I'm coming to you.
You can use my microphone here.
Thank you. Thanks so much. This has been such an interesting and uplifting morning. My question is around, like, I know what the statistics you talked about with social media are very disturbing, and I've heard a lot about that. But at the same time, people also look to those for community and connection. So how do you reconcile, like, how do you use social media for community and why it doesn't work for people?
Really, really great question. I think, so yeah, social media was social, right? Like that was what it was put out to be. It's interesting that we have this dichotomy between social media creating more isolation. I think one of the challenges is social media platforms are using algorithms to fill your news feed, to fill what you're seeing. So I purposely did this experiment on my phone where I eliminated everything that didn't have an animal or cooking in it, because those are the things that bring me joy. Those are the things that get my mind going. And the vast majority of my news feed stays with that content. But I know from just talking to my own kids, they'll be like, oh, we just saw blah, blah, blah. And I'm like, how'd you see that? Like, how did you, oh, it was here. And I'm like, so I think the challenge is we've used AI to create models that keep people engaged. And some of that is sensational. It is the outrageous. It is the detrimental. It is fake news in kind of the grown-up world. But when we click on it and we engage in it, even if we're just curious, it's going to populate for us. So I think that's part of it. But I think the other piece is education, right? It's being able, we have this conversation with our kids, it's being able to say, here's the risk. You know, the people that we see, used to be back in the days of magazines, like when we pick up a magazine at the grocery store aisle, that was social media. That was the influence of what bodies were supposed to look like and how put together we were or weren't supposed to be. And everybody wakes up in the morning with like makeup on their faces and their hair done. Like that was the pressure that I remember as a young person. And now that is like so exponentially influential in people's life that they see a picture. And what we see in that picture, we take pictures usually of good things. We're not taking moments when we're not able to get off the couch or exhausted or in tears or dealing with grief. That's not what we do. We put forward our good pictures, right? The beautiful, the perfect. And when we're on the outside of that and we see that, that's what we assume our life should look like too. So it doesn't leave space for the range of human experiences. It really just highlights what our culture has said is perfect or good and frankly unattainable. So really great question. I don't know that that answers it fully, but I think education is part of it. I think being very mindful as adults of what our children are exposing their brains to is really important. Having conversations and limiting. Sheer numbers matter. Thank you.
Please join me in thanking Dr. Dial.